This recording or short lecture is about gingivitis and periodontitis. Not the definition, not what you have been, what you learn in your first, second year. It is about two classic papers that I tried to simplify it and put it into words that you can remember the concept. You don't need to know any of the percentage. It's not going to be in your exam what are the actual details of this study, but I want you to understand the concept. So I thought in this way you will remember it better, because this is how it was in my dental school. Okay, so the first one is experimental gingivitis in man. It's an old classic paper. I can tell you all periodontists, they know about this. You basically, it is like a very basic and fundamental papers in the residency level. This classic is papers by Lowe, and it kind of tells you what is this gingivitis, how long does it take for people to develop the clinical signs of gingivitis. So what he did was very smart that time, with not like very established system of research. What they did is that they selected 9 first-year students, 1 teacher, which was a periodontist, and 2 lab technicians. All of these people, the baseline, they didn't have clinical sign of inflammation, and they had good oral hygiene while they were dental students, I think, or maybe a perio resident. So they recorded their plaque index and gingival index. And all subjects, they had plaque index and gingival index of less than 1. So now we use the binary code. It's plaque or no plaque and how many surface. But they use this plaque and gingival index that you see here. Just put it here. You don't need to know them, and I doubt it will be in your exam, but please refer to Dr. Lang's lecture if she require you to know this indexes or indices. So they recorded their plaque and they recorded their bleeding and or the sign of inflammation, basically not bleeding, based on this chart. So, and what they did is that they record the baseline, they ask them stop any sort of oral hygiene, no brushing, no flossing, nothing. And they follow up with them again. They repeatedly record their plaque index and the oral hygiene index, or basically the gingival inflammation of the plaque. And what they observed in this study was that all the subjects developed the signs of inflammation, gingival inflammation. However, it took different time for them. They were in different time frames. Some of them, they had sign of inflammation 10 days after they stopped brushing, flossing, and any sort of oral hygiene practice. But the majority of them developed the signs 15 to 21 days. Okay, I'm not saying you don't brush and floss and you should be okay for 10 days or 15 days. It's about the response. It's about the response of your body to the inflammation or insult of bacteria or plaque. Yes, people, they will develop the symptoms in one spot. That, let's say you clean the facial surface of number 9, that specific spot may take around 10 days or 21 days to have the symptoms of inflammation, but not every time people, they brush, they clean all surfaces of their teeth. So this is why, based on other sort of studies that we have, it's recommended to clean all the surfaces of the teeth twice a day. Okay, going back to the finding. And the other interesting thing is that they observed that they got inflammation, gingivitis, And when they resumed the oral hygiene, everyone got back to the healthy, clinical health gingiva. So it means it was reversible. That's why we're like insisting gingivitis is reversible, periodontitis is not. The other classic paper that I would like to have both of them in one presentation is about the natural history of periodontal disease in man. It's a very interesting population of people involved in this study. There are tea plantation worker in Sri Lanka, and this group of people, which is still low, that he's one of the famous names in classic literature. They follow up with these people for 15 years. So, and based on their finding, which is basically will be a prospective study, they collected very interesting information about this specific population. And the other interesting thing about this population is that they haven't been exposed to any sort of supervised or education of oral hygiene. So basically, they didn't brush or floss, and they were all men, and basically kind of the same age range, and most probably some sort of the same diet they had, because they were like very isolated group of people. I put the abstract of this paper here. You don't need to read through that. If you're interested, I would encourage you to read it. So it is a very well designed, nice study in that time that they did. What was their findings? So they follow up with these people from they started the research in 1970 and then follow up with them until 1985. So these people, they grew. They were like older when they went back. So, and the age range is from 14 to 46. They found, based on the interpretation of this data, that they can put this group of people in three major groups. One is rapid progression of the disease, moderate progression, and no progression. 8% of this population during this follow-up time, they had rapid progression of the disease. And you can see the annual rate of destruction was annual rate of destruction was 0.1 to 1 millimeter. 1 millimeter of attachment loss is a lot of attachment loss, like 10 millimeter in 10 years basically. So what you can see is this 8% of people, they lost all of their teeth at the age of 45. The other group, which is a majority of the group, are 81%, they're moderate progression of the disease. So the annual rate of clinical attachment loss was 0.05 to 0.5 millimeter. The no progression disease, it means like they didn't brush, they didn't floss, they didn't have an actual practice of oral hygiene. However, 11% of these people, they had no tooth loss during this time, and the annual clinical attachment loss, as you see, is very minimal. It's 0.05 to 0.09. So based on this interesting finding, I want you to think about it. I want you to take some few seconds or a minute and look at this data. So the majority of this population, they didn't brush and floss, they had moderate rate of progression, 81%. Very small group of people, they had rapid progression, and very small group of people, they had no actual clinical attachment loss, or very minimal clinical attachment loss. There was like lucky people that you see here. You can link it most probably to genetic, but because this study is not specifically about genetic, I cannot conclude that. But what the first thing comes to your mind is that it should be something about genetic of these different people, even though they're from the same group and most probably same ethnicity, same kind of like practice of oral hygiene, if they had any, which has been mentioned, they didn't have any, and the same diet. So, I want you to answer these two questions on Blue Line. I'll post it there. The first one is that you point out plaque and bleeding and probing to your patient while um, sitting in your chair. And the patient says, "Oh, it's because I came from work and I didn't brush today, or I was busy yesterday, I had a gas, and I didn't like brush last night." What is your response? So focus on plaque and bleeding and probing. What do you think? What comes to your mind, and how would you elaborate that based on the experimental gingivitis study? The other thing that I want you to maybe explain each of this question very short, like few sentences or like even one sentence. What do you think? What comes to your mind? The first sentence that comes to your mind. Natural history of periodontal disease and grading. So natural history of periodontal disease, they finished it in 1985, 85 or 86, I can't remember. Uh, but I was basically born exactly that time. But this grading is from 2018. So there has been thousands, I would say, if I'm not exaggerating, studies about genetic, about perio disease, about systemic disease. Technology has changed. There was a lot of study came after between these two times. So when you look at this grading, you have grade A, slow rate, moderate rate, rapid rate. And then you have bone loss, then you have plaque deposit correlates to this grading. I want you to, just in one sentence or two sentences, look at the primary criteria of progression of the disease in grading that we use nowadays and compare it to the natural history of periodontal disease. And thank you for listening to this, and I hope it was helpful and it will help you in your future career when you deal with gingivitis and periodontitis.